am Dr. Shailendra Singh. I am an Associate Professor of Medicine and an Advanced Endoscopist at West Virginia University in Morgantown. My co-authors are Dr. Arunkumar Krishnan. He is an Advanced Endoscopy Research Fellow at West Virginia University. Dr. Yousaf Hadi is a third-year Gastroenterology Fellow at West Virginia University. We would like to thank the Endoscopy Journal for providing this opportunity and choosing our study for a personal video statement. The title of our study is Endoscopic Management of Gastrointestinal Wall Defect, Fistula Closure, and Stent Fixation using through-the-scope tack and suture system. With the recent advances in the field of endoscopy, now large early neoplastic lesions in the gastrointestinal tract are being removed with endoscopic mucosal resection or endoscopic submucosal dissection. This results in large irregular defects, and hence there is a growing interest in endoscopic closure of these larger defects to decrease the risk of complication. Recently, a novel endoscopic tack and suture device was developed to overcome the limitations of currently available devices. This through-the-scope suturing device eliminates the need to withdraw the endoscope from the patient before applying therapy and can be used with both endoscope and colonoscopes for closure of large defects, especially in challenging and difficult locations. We also utilize the suturing device at our center for stent fixation and closure of fistula in challenging locations. The device comprises of 4 helix steel tacks preloaded on a suture. Each helix tack is deployed sequentially using a catheter placed through the working channel of an endoscope. The tacks are penetrated in the tissue adjacent to the mucosal defect, or stents in case of stent fixation, at the level of the muscularis, and then these tacks are approximated by applying tension on the suture and placement of a final suture cinch to achieve mucosal closure. Currently, there is limited data on the outcome of this device, especially with long-term follow-up. Therefore, we aim to assess the feasibility, safety, and outcome of this device across multiple indications, including closure of large gastrointestinal defects, fistula, and stent fixation.
We observed high technical and clinical success for gastrointestinal defect closure with helix tack device. Technical success was achieved in 96% of the patients with the mean defect size of 32.6 mm. Clinical success was achieved in 92% of the patients. The durable defect closure was observed with the device in our cohort at mean follow-up 7 months. The clinical failure was observed only primarily in the fistula closure. This study adds important clinical data on the safety and efficacy of the device and provides the important insights regarding its use across the various indications.
Our study has a few limitations, including its retrospective nature as well as its single center design. Furthermore, a single endoscopist experienced with endoscopic suturing was involved in all procedures. The next step will be to compare this device with the use of endoscopic clips for defect closure in terms of efficacy and cost effectiveness. Further data is also needed to identify which fistulas may be amenable to closure by this through-the-scope suturing system. In conclusion, this through-the-scope suturing device is a valuable addition to endoscopic closure devices. This device is safe and can achieve high clinical success in closing large irregular defects in difficult locations, which would otherwise be challenging to close using other available devices. This device avoids the need for withdrawal of the scope and reinsertion and can be effectively combined with through-the-scope clips as well.
Thanks again to Endoscopy Journal for publishing this study, and thanks everyone for listening.